Welcome everybody to our TIF talk today. I'm Andrea Millers. I am the Director of Marketing for Endogastric Solutions and the TIF procedure. I'm happy to welcome Dr. Michael Murray, who's here with us today. He is the Assistant Clinical Professor at University Nevada, Reno Medical Center. He's also the General Surgeon at Northern Nevada Medical Group. So welcome, Dr. Murray, and thank you for being here today.
Thank you, Andrea, for having me.
Yeah, so we are on Facebook Live, and we're just going to wait a couple of minutes and make sure we get a couple of people on. But today we decided, since we're both, remote, we are going to do it a little bit differently. We are going to do a Q&A. So we have quite a few social media platforms, if you will, or groups that talk about TIF, the TIF procedure, that have questions about GERD. So today, what we'd like to do is take some of those questions that we get on these group pages and answer them with you today, if you're okay with that.
Great, that sounds great.
Okay, wonderful. So you've been doing TIF, let's get a little background. You've been doing TIF for about 10 years now, right?
10 years. I kind of been with it for a long time as the device evolves and as we got more and more data with it, and it looks like it's, the data is coming out that looks really good. I have some patients in my practice that are 6 or 7 years, and I've pH tested them again, and their pH tests look really good. So I'm really happy with the device now, and I'm happy with the results. And the patients that have gotten it are happy as well. They do very well with it.
Wonderful. Well, thank you again for being here with us this afternoon. We appreciate it. So one of the, let's kind of the big elephant in the room, if you will. We've seen a couple of questions that have come up about COVID and their GERD symptoms. So let's just kind of like hit that and then let's get straight to that. So some of the questions that have come up, one person said, I just had my TIF procedure on February 13th. Does this make us more vulnerable to COVID-19?
So I wouldn't think that a TIF procedure would make you any more susceptible to COVID-19 than before having a TIF. I mean, no one has immunity to this disease naturally. So you're only going to get immunity as it goes through the population. So TIF is just a mechanical valve. It creates a high pressure zone down at the lower esophageal sphincter. I think there's no real reason why that should give you any more susceptibility to this virus than normal. I think I would suggest getting off PPIs sooner, because we know that PPIs do increase infectious rates in the GI tract on almost everything. And we know that there are some of these ACE2 receptors in the GI tract. And so COVID-2 does have GI tract symptoms. So I'm not a big fan at this time with this disease going around of decreasing acid in your stomach. Acid could certainly denature this organism.
Okay, interesting. So that was the next question, actually. Someone asked the question, my GERD has significantly gotten worse during these stressful times. Should I up my PPI medication? Do I need to ask my doctor, or should I just take it over the counter?
Yes, that's hard. So managing stress during these times is really important. I think this is not going to be something that's going away in 2 weeks. I think we ought to accept that fact. This is going to be around for a while. I think it's important to make your body as strong as possible should you get the infection. I'm a big fan of that. In surgery, we do these things called preoperative optimization, where we try to get people strong for surgery, because we know surgery is a physiologic hit to them. So, and so some of the same type of things that we do for that, I'm kind of discussing for my patients. And one of those things is we try to get people, off the PPIs if they have to have surgery or come into a hospital because they're more prone to get infections. We try to make sure they're nutritionally optimized for any kind of stress. And this is kind of what people should be doing right now. You can't just hunker down in a house and hope this thing passes you by. Sooner or later, we're all going to try to get exposed to this. So make yourself as strong as possible.
Sure. Okay. That's great advice. Thank you. I appreciate that. So let's go ahead and ask some of the questions. I'm going to ask some of the questions that have come up on these TIF groups. So first question is, what's the most important thing to avoid in GERD along with hypothyroidism? It's an interesting question.
Yeah, so in terms of GERD, I don't think hypothyroidism is going to affect it too much. I mean, the body is a complex, integrated system. I mean, hypothyroidism will, increase its own number of stresses on your body. So it should be easy enough if you have hypothyroidism to maintain a thyroid level that's in an optimum range. So you should be seeing a private medical doctor that's optimizing your range of thyroid medicine to keep what we call your T4 at a good level and your TSH not too high, not too low. So those are the tests you would get to make sure that's at that level. And then the usual things for GERD would be not to overeat. If you're on a medication for the GERD, keep taking that. And otherwise, the usual things they say, keep your bed elevated, don't eat late at night, don't lay down after eating, the usual things like that. But there's no specific thing that really relates those two diseases, GERD and hypothyroidism. They're both kind of independent diseases, and they both have to be managed separately.
Okay, thank you. I appreciate that. So next question, is taking allergy medications okay with GERD?
Generally so. It depends on the medications. In my practice, I am seeing a lot more of these esophageal candidiasis or yeast infections of the esophagus, particularly in people taking nasal steroids and things like that. So sometimes they come in, they think they have terrible GERD. It causes a burning and pain when you swallow sometimes. So that can be a side effect of taking these steroids, the nasal steroids, like the nasal cortisone and things like that. But otherwise, generally, it's fine. If you're having a lot of pain swallowing and things like that, you may need to be evaluated. Esophageal candidiasis.
Okay, that's interesting. That's actually a good question because, as spring has come, everyone's with everybody cooped up in house, they're trying to go outside and taking walks and whatnot. So they may confuse allergies with symptoms from COVID, possibly.
With COVID, trying to take, nasal steroids or these things that really depress your immune system, I'm not sure that's a great idea. You may have to bear with it a little bit this year.
Interesting. Okay. Thank you. So another question. I've been suffering with gastritis and GERD since November. I've been on Protonics, which took the burn out of my chest and stomach, but my throat still feels like there's something in it. Is that normal?
It can be. So the higher up you go in the aerodigestive tract, the more sensitive it is to acids. So it kind of makes sense that if you're having LPR, laryngeal pharyngeal reflux, that's the last thing that gets better. The gastritis, the GI tract cells will turn over in 3 or 4 days, and you get the gastritis will heal up fairly rapidly.
Sure.
The esophagus will a little bit slower, and then the tissue higher up in the field will last. So that's very common for that to happen.
Okay. Okay. Here's one you probably hear all the time for your patients. Help! Everything burns in my stomach. What do I do?
Yeah. So if you get to that point where nothing's helping anymore, it's really time just to be assessed. We know that 25% of the people with reflux are going to get a progressive disease that's going to get beyond what the pills can do. And they're going to need some kind of mechanical fix. We know that. There's data out to support that. So if you're having issues with burning all the time, it's every day, nothing seems to make it better, it's time to get evaluated. I would say the evaluation of choice would be an upper endoscopy, get evaluated, see if you have a hiatal hernia, which could be leading to that. And at the same time, do what's called a 48-hour pH test, where you implant this little microchip in the esophagus, and it stays in there for 2 days, and it measures how many times you have reflux, and it gives you a pattern of what your reflux looks like. So that's important to us as physicians that treat reflux, to know what's called the phenotype of reflux, or what's happening on a daily basis. So I think that would be the most important test to get, to see where you fall on the spectrum, right? It's a spectrum disease. We know there's not too bad a reflux, and then there's really bad reflux with hiatal hernias and a lot of anatomic issues. And you want to know where you are on that spectrum.
Yeah. So to that point, if there's someone out there that's feeling this pain all the time, is there a specific doctor that you recommend they go see? Do they need to see a gastroenterologist? Do they come to see you, a general surgeon, their regular PCP? What do you recommend?
So usually they end up at their PCP and they'll generally get on a PPI, and then usually the story is they'll be managed by their PCP for a little while, and then they'll outgrow that and they'll end up with a GI. He'll take a look and ended up on Dexilent, which is kind of the strongest PPI there is, twice a day, and then that's not working. And then basically they end up in a GERD center like I have, where nothing's working. I've been through all these processes and I need something different. So then you're looking for a mechanical fix. I mean, it's a mechanical problem. We decrease the acid in your stomach to decrease the burn, but it's not always the answer. Sometimes you need to move to some more aggressive approach, whether it's a straight TIF or some hiatal hernia and a fundoplication at the same time.
Okay. Yeah, that's great. Okay. So next question, what is the success rate of the TIF procedure?
That's tough because it depends what you consider success. For me, I think getting people off of PPI daily is success for me. I'm getting more aggressive about testing my patients, doing another pH test after we do the TIF procedure to make sure that I do have solid, evidence of acid control. But sure, maintaining them off of their PPI, I think, is a win. Every year we learn that PPIs have a lot more side effects than we initially thought. And so if we can keep you off of those medicines and you can resume a fairly normal lifestyle in terms of your eating, then I think that's a win.
Yeah, no, that's a good point. And we just actually got a question on Facebook right now from Rocky. He said, what pills are you referring to, and are they only prescription?
So no, the pills I'm referring to are called PPIs, or proton pump inhibitors. And those are the ones that you see advertised all the time. There's a $14.5 billion a year industry in 2010 dollars. They are available over the counter. Almost every one of them is. So the common one, the first one that came out was Prilosec. There's Nexium. There's Protonix. These are all over the counter. You can go into Costco and buy them by the case and treat yourself. You don't even need to see a doctor. So when you go see a doctor, generally we up the doses and maybe give you some of the stronger medicines that need a prescription, like I was suggesting, Dexilent. There's other medicines that have been out even longer called H2 receptor antagonist. One was just in the news, Zantac, as being a cause of cancer, so it was getting pulled off the market. The only one in that category that's fairly common is Pepcid.
Right. Perfect. Thank you. I appreciate you answering his question. So does high protein cause more trouble with GERD?
It depends. Not necessarily. There are certain things that cause people to have GERD. They're what we call triggers. And some people, it's the classic ones are chocolate may do it, or caffeine. So if someone eats a big steak or something, they may get GERD, and they may be kind of associating that with the high protein meal.
Sure.
When it may not necessarily be that. It may just be that the valve is kind of weak, and if you fill your stomach too much, you're going to get reflux. So protein in and of itself shouldn't cause any issues with increasing reflux.
Right. We have another question on Facebook from Lynn. How long, Lynn Benoni, how long is it safe to take, it says decals too, but I'm assuming she's probably saying how long, probably she's talking about the PPIs, probably Dexilent or.
We're changing our ways. These were prescribed kind of willy-nilly to anybody with any kind of abdominal complaint. We thought they were very safe, but as it turns out, they cause all kinds of issues in terms of the bacterial flora of your gut. They cause issues with bone loss in women, which is an issue anyway. So calcium absorption is not great with them. And there's just you can go online and find just a ton of things that are not great about taking these pills every day.
Right.
Acid in the stomach is a preserved evolutionary thing. Every vertebrate has acid in the stomach, and these pills can be very strong. They stop acid production completely. And it's probably just not a very good idea. There's acid in your stomach for a reason. Just shutting it off, not necessarily that great an idea. There is no really how safe you can take these. There's long-term side effects over time, and you're going to be at risk for them as long as you're taking them. And so if you have to take them, you should take the minimum dose and try to decrease the interval as much as possible to keep your symptoms under control.
Perfect. Thank you. We've got another question that's just popped up on Facebook. Has TIF been proven effective for laryngeal or nasolaryngeal? I think they're probably talking about LPR reflux.
Yes. So, yeah, there are studies out there to show that it is great for regurgitation in LPR. LPR is where you're kind of getting the acid way up in the back of your throat. And this is usually from episodes of regurgitation. And the pills really are not very good for that. Or there's other things in the gastric contents other than acid that can cause irritation. There's bile, there's pepsin, which is a proteolytic enzyme that can be reactivated later and cause kinds of tissue damage. So for people with really bad regurgitation and LPR, a mechanical fix is going to be better generally than the medications.
Yeah, great. Thank you. So another question here is, if you have GERD and a hiatal hernia around 2 centimeters and delayed gastric emptying, T half 135 minutes, I think I said that right, can I get a TIF procedure?
Yes, but you're complex. And so it's hard. I see a lot of patients like this who you do the endoscopy and it looks pretty good and there's not a big hiatal hernia there, and you're wondering what's going on. You do a pH study and they have a really high acid exposure time, and those people, I'm very suspicious that they have gastroparesis and they're getting this backwash reflux because the stomach's not working very well. It's really important when you study someone that you know what's happening in the stomach below the valve, and also what's happening in the esophagus above the valve. It is what I call a kinetic chain. You have to understand what's happening in both areas if you're going to really make a difference in this person. So this person with gastroparesis, I don't know why she has gastroparesis. There's 3 types. You can have it from diabetes, which is the worst. You can have it from previous surgeries that injure the vagus nerve. And the other catch-all group is idiopathic. But it's really important, if you're going to do an anti-reflux procedure on these patients, is that you discuss with them the need to not go greater than 270 degrees in the rack, because they count on burping and getting gas out of their stomach to maintain comfort levels, and you can give them really bad gas bloat. You may want to address maybe trying to make the stomach empty better with certain medications like metoclopramide, or with a pyloroplasty or a G-POEM, these other types of procedures. So these people, you have to make sure you don't make them worse. You can fix their reflux with a TIF, but you have to be careful with them too. So,
perfect. Thank you. Next question. What tests should you do to know if your hiatal hernia can be treated without incision in the same TIF procedure?
Yes, so that's a tough one, because we know that hiatus, those 2 bands called the crura, count as an external sphincter on the esophagus. So it's hard to address reflux without addressing that sphincter too. It often becomes dilated and is dysfunctional, in addition to the lower esophageal sphincter, the high pressure zone in the esophagus. So both of these things generally have to be addressed. But if you are one of these patients with a really just a low pressure in the lower esophageal sphincter, and you don't have a big hiatal hernia, which is anything over 2 centimeters. So a TIF is for someone without a hiatal hernia, a straight TIF. So if you're looking to get a procedure without any incisions whatsoever, your hiatal hernia has to be less than 2 centimeters.
Okay.
And that's really important, because if you try to do the TIF in the face of a hiatal hernia, it's not going to work. It's going to fall apart in a year or 2, and you're not going to be happy. And you're just better off those 4 little incisions that it takes to fix the hiatus, and a minimally invasive approach there.
Right.
Because it's not going to add very much to the outcome and to the discomfort, but it's going to add a lot to the overall success of your operation.
Okay, great. Thank you. So next question is, I had the TIF 5 days ago, and it seems like my shoulder pain is getting worse again. Also, it goes into my neck. Is this normal?
So you can get this shoulder pain up into the neck, and what that is called a Kerr sign, and it's from irritation of the diaphragm. So even if you had a straight TIF, and I don't know if this person had a hiatal hernia repair at the same time or not, but often that's the thing they complain of the most. And I always try to explain that to my patients. They'll generally wake up with that pain in the shoulder. It's kind of surprising to them. They think they had a rotator cuff or something like that.
Wow.
And it'd be fairly intense. It generally goes away in 6 to 8 hours after the procedure, but it can come back. And generally that's because you get a little blood under the diaphragm, and that blood causes inflammation. And generally, my patients, I suggest they take an anti-inflammatory, although I guess we're not supposed to take ibuprofen now with COVID around. Yeah. So generally, I would usually have them take 2 or 3 ibuprofens with a meal just once a day for 3 to 4 days, and that usually will take care of it. Okay.
Okay, thank you. Does the acetaminophen do the same thing as the NSAID, or?
So it's not as successful as an anti-inflammatory here. So in those cases, if it's really getting bad, then just take a few days of ibuprofen will make that go away.
Okay, perfect. So next question, I had TIF on Monday, and I'm feeling better each day, just hungry. I am lactose intolerant and type 1 diabetic, so protein shakes aren't very friendly to these things. Do you have suggestions or examples for diet day 4 through 13? 4 through
30. So in my patients, and I don't want to step on any toes because some doctors do it differently in terms of advancing the diet, I consider, swallowing to be physical therapy for the esophagus. So I move along faster than Gastric has as a diet. So in my first week, I keep them on liquids. It could be any blended liquid. You don't necessarily have to have protein drinks. I mean, you could make your own type of things. Any kind of soup that you put into a bullet blend is fine. And then on like week 2, when they start that, I'll have them do some eggs if they're hungry, getting some protein like that, and some scrambled eggs, mashed potatoes with gravy, even like some mac and cheese. It's really cooked really soft, so they have something to chew and cheese, and that'll kind of take away those hunger pangs.
Okay. Oh, this one's, I'm wondering if you get this question ever. Does vinegar and honey work for GERD symptoms?
Yeah, so there's all kinds of things. People take aloe, and there's all this homeopathic stuff out there. Some people now take CBD oil and all other kinds of things. And there are CBD receptors in the GI tract. I looked at that, but it does cause your lower esophageal sphincter to open more, so it's probably not good. But yeah, so I don't know what to say on these things. I tell people, they'll come in with a whole load of these special medicines and supplements, and I practice allopathic medicine. I try to have an open mind. Some of those things may work or may not, but I'm not really up on all that stuff. So some of these honeys have been good. I've Manuka honey has certain medical and medicinal value, but I'm not going to say that's the best way to treat your GERD. I think the best way to treat it is to, again, get a pH test and see where you are on the spectrum. If you have really mild GERD, and that's the area, then by all means.
Yeah. Okay. Thank you. So I have a sleeve. Can I get the TIF?
Yeah, this is a real problem. I see these patients all the time with terrible reflux. Know that if you didn't have reflux and you had a gastric sleeve, 40% of those patients will go on to get pretty bad reflux. And the reason is because they come up that sleeve and take the fundus, and they take these sling fibers that make up part of the valve there. So even if you were doing well beforehand, a good chance you're going to have reflux afterwards. Unfortunately, when they take the fundus, that part of the stomach is what we use to wrap and make things tighter. So no, right now you really can't have a sleeve. If you have a really kind of dilated stomach, we could do something to kind of, maybe get in there and do a type of TIF. But right now, those patients are a real problem. can address their hiatal hernias, and do these other types of things, but it's really becoming a big problem. And they really should be evaluated for reflux before getting the sleeve. Because some of these patients have terrible reflux beforehand, and they should end up with a gastric bypass would be better for them than a sleeve.
Yeah, yeah. Okay, thank you. So this one's interesting. This person had their TIF this morning with no issues during surgery. I'm currently still in the hospital recovering and experiencing extreme nausea. Felt the urge, TMI, she says, vomit twice and dry heave, but nothing came out either time. I was painful and I'm worried. Oh, it was painful and I'm worried I already messed it up. Is this level of nausea normal? And she said she tried to eat a small bite of Jell-O.
Yeah, so postoperative nausea and vomiting is a real pain on some of these cases. And the really best thing you can do is avoid it. So, I mean, when you're doing a TIF procedure, it's important that you're working with your anesthesiologist, that they get a dose of Zofran before, that they get a dose of Decadron before, that they get the scopolamine patch. And so you do all these things up front to avoid it. Once you get postoperative nausea and vomiting, it's difficult to control. And it's unlikely she tore it all up just by doing some retching. I see a lot of patients will do a little bit of retching and everything's fine. It's just one of those things you're going to have to go through. It does cause some pain. Particularly, I find people that have a straight TIF sometimes have more pain than those that have a small hiatal hernia and a TIF. I don't know why that is. I think we have better. Once you take down some of the adhesions, tissue moves better and it's not under as much tension. But postoperative nausea and vomiting, she should be better, by tomorrow, the next day. So you're just gonna have to go slower and then stick to liquids and make sure she has her Zofran available.
Yeah, good point. So the next question, which is the best, the best effect and ultimate treatment for acid reflux LAX LES? TIF procedure or Nissen fundoplication?
Yeah, so it's hard to say. I still do Nissens, but it's usually just for really big hernias, big hiatal hernias. So, so the best operation is an operation that fixes the problem in a minimally invasive fashion with the least amount of side effects. That's the best operation, no matter what you're doing. So. That's why they do cardiac valves with going through a femoral artery now instead of opening your chest. So TIF's kind of that same way. TIF allows us to do fundoplications and things we had to do with kind of a lot of intervention. We used to have to do a lot of dissection, and Nissen does take a lot of dissection. Not everyone has a loose and floppy fundus that they can wrap around the esophagus easily, so the dysphagia is much more common with that operation. And gastric is much more common with that operation. So for strictly controlling reflux, I think TIF's probably going to be the least invasive and have good effect. And so it doesn't burn any bridges. Later down the line, you could have a Nissen fundoplication. Once you have a Nissen, they're hard to redo. I mean, basically, we give you like maybe one more shot after that to redo a Nissen fundoplication. So again, always go minimally invasive, least amount of side effects, least amount of surgery.
Yeah. So that's a point. There's possible to do only the hiatal hernia repair first and then wait for it to heal to do the TIF procedure.
So do a staged procedure. You can do that. I've done that on people that had previous surgeries and things like that. But I think, if you're there, it's best just to get them both done at the same time. Yeah. But there are, indications sometimes for doing a stage type procedure. So.
Yeah. Okay.
Surgeon, but it's generally not what we do. We generally do everything in one fell swoop.
Yeah. Okay. Probably we've got a couple more questions here. This one's interesting. I had the TIF done almost 5 years ago, and I can't complain until now. I had my annual upper GI, and they found my twisties, I'm assuming, in my esophagus are eroding. Has anyone else had this or heard of it happening? And then what do I do next?
Yeah, I don't know, if an upper GI is really the answer to that question. I mean, are you having reflux again? I mean, you should basically have a pH test and have an endoscopy to take a look at what you have and what the wrap looks like. And having reflux again, you could definitely re-TIF these patients if you don't have a hiatal hernia. So I think, sometimes the wrap does come undone. It gets loose. We know that happens with Nissens. It happens with anything you do to the stomach. So we know that people that have sleeves, they get, they dilate up and they can gain weight again. So, but the answer is, upper GI is just not going to give you enough information there. Get a pH study, have someone take a look at that wrap and see if it needs to be tightened up.
Perfect. Thank you.
Take a break for a second and plug my computer in because I got a low battery here.
Okay.
So,
yeah, plug it in. This is live.
It's going to go live.
Hey, everybody. If you have any questions for us this afternoon and you're on, please feel free to ask us a question. I do see quite a few questions popping up on Facebook. So thank you. And when Dr. Murray gets back, we'll make sure we get those questions answered. So I hope everyone's at home, staying safe and doing some social distancing. Here's Dr. Murray's back. I was just talking about everybody staying safe and healthy and doing some social distancing. We actually got a question that popped up. And I know you addressed it when we first started, but there might be some people that didn't jump on until later. And the question was, what can I do while I'm stuck at home, social distancing, to try to relieve my GERD symptoms until I can go in to see a provider?
Yeah, so this is a real problem right now. It's hard to get in to see providers because we're trying to keep people out of hospitals. We do not have the protective equipment to do elective procedures even. So we can't even do a scope on you and figure out what's going on. So this is really tough for everybody to get this plug.
Right.
So I think that the thing to do is try and make sure you're eating right. I mean, these are tough times. You don't want to get into stress eating, right? So don't go to potato chips, sitting on the couch. You have to maintain your exercise regimens. Like I said, I would really try to make yourself robust in case you need, if you're going to get hit with this thing, you want to get hit when you're strong, right? So if you're at home, social distancing, you may want to cut down the alcohol, right? You may need your liver to make some acute phase proteins. That'll also decrease the GERD. Don't eat too much. Have a regimen where you're eating. Usually people, when they're at work, they have they get a lunch break and that's all they get and stuff. But at home, it's easy. You get bored. You want to go to the refrigerator. So you have to maintain your regimens. Maintain, if you have a fasting regimen, maintain that. Don't eat till noon. Have one big meal a day.
Yeah.
Watch the alcohol, and that's the other thing. Keep your exercise going. It's not easy.
Yeah, that's a good point. Oh, this is a funny one. I think you'll get a kick out of this. Someone said, I'm on day 6 post-op coffee. Her name is Coffee, or his or her name, I think Coffee. So I'm on day 6 post-op. I danced a little too hard last night. Did I mess up my TIF?
Danced too hard. Oh my God.
They're happy. They're happy with their TIF.
So usually we consider, I don't think dancing's that bad, but I think, any lifting or anything like that, anything straining, pushing, pulling, we tell you not to do, not to lift anything over 10, 20 pounds. If you had a hiatal hernia repair, obviously you can't do anything like that. But, I tell people to get outside. Walking is the best thing for them. I don't think dancing's going to hurt you too much. So I doubt you messed up your TIF by dancing. I don't know what you were drinking last night, more or less, but the dancing didn't do it for you. TIF can withstand some dancing, I think.
Yeah. We need that a little bit for now with these days, right? So I got another one. Would you recommend TIF for a 2 to 3 centimeter hiatal hernia? I'm 38 and in good health and weight. Recent surgeon told me TIF is for old people, and Nissen is the gold standard. I don't know that to be true. Can you chime in?
Yeah, so it depends really on your comfort level. I think, why would you say TIF is for old people? I think TIF is better for younger people. I think it's changing the paradigm. What we used to do is just treat people with these medications until they couldn't take it anymore, and their hernias were huge. And
Right.
that by the time they got their 60s and 70s, and then we did a Nissen on them. I mean, so I think we don't like PPIs as much as we used to in the 80s and 90s. When they first came out, we thought they were the greatest. So I think the best thing about a TIF is it doesn't burn any bridges. She has a small hernia, someone like that. You can just do a small window laparoscopically, put 2 stitches in the hiatus, increase the intra-abdominal esophageal length, and then get out and do a TIF. Why would you? For a Nissen fundoplication, when we talk about that, that's mobilization of the entire fundus of the stomach, which means cutting all those blood vessels, coming close to the spleen, which could cause a splenic injury. You can get bleeding. You can get a perforation of the esophagus or stomach. And so it's a little bit more risky. And so if a hiatal hernia and a TIF would control her symptoms for 10, 15, 20 years, then why would you do something more?
Yeah. Yeah. Well, can you talk a little bit about also the not side effects, but the post-op issues that can come up with Nissen versus the TIF procedure? Because TIF has significantly less post-op.
Yeah, so Nissen is a more aggressive option, and you know, guys that get on the robot nowadays, they don't want to stop and get off and do it. They're there already. So, but being there doesn't make that the best operation. The best operation, as I stated earlier, is going to be the one that's the most minimally invasive, the least amount of side effects, and the safest operation. And it's hard to say that comparing a TIF to a Nissen, you're going to be bigger side effect profile, bigger adverse event ratio. So, I mean, you get more risks as you bring that device close to the stomach near the spleen. As you're dissecting here, you use these energy devices. That energy can bleed into the stomach. You can get a perforation you didn't recognize. You can injure the spleen. You can do all these things that make an otherwise safe operation not so safe. Now, you know, you can say that in experienced hands, that's very uncommon, but it can still happen. So, you know, like I said, I still do Nissens. I think there are some people that need Nissens, but a 3-centimeter hiatal hernia, that's not one of them. That's in my book. That was someone that needs a less invasive option.
Right. Well, so this gentleman, it's actually a gentleman that asked the question, I believe. He's also in Nevada, he said, and he wants to know where can he see you. So tell him where you're at.
Yeah, so I'm at Northern Nevada Medical Center in Reno. So you can get a hold of us. I think they'll have it on here at the end of where you get a hold of us. So yeah, that's just too much operation for that state of disease is how I feel about it.
Yeah. Okay. There's a lot of questions, so maybe I'll do 2 more questions and then we'll let you go. So
we're good.
Okay, good. Okay. Yeah. And if you're good, then, but so what is the success rate? And I know you answered this a little bit, but she's saying the success rate of TIF, and should I stay on Represent 40 milligrams for life? I think you answered that already, but maybe you can answer it again.
So success rate, I think over 80% or 80% is usually the success rate that's quoted to getting you off your PPIs. I think that's fair. Some people will take them on demand and not be on them every day. But that's what I consider the success rate for controlling reflux. You may have some reflux down the line years out that may need to be addressed again with a redo procedure or tightening the TIF up or maybe manage it with some medications as things loosen up over time. But I mean, taking pills every day is hard to, people don't assess that risk very easily. It's easy to assess the risk of a surgery, right? You walk in there, if everything goes good and you wake up in recovery and everything went well, usually it's not too bad. It's sort of like flying on a plane, right? So it's the plane goes up, you go and it lands, things are good, and there's not a side effect later down the line. Generally, like 20 years from now, you're not going to get renal failure or something like that. Right. Whereas when you're taking a medication every day, it seems like it's pretty safe, but these things, the risk builds up over time, right? So there's a famous quantitative guy named Taleb Nassim who talks about that. The comparison of that would be like rolling over rocks in the Mojave Desert. If I paid you $1 to roll over rocks for every rock you rolled over, you think that's a pretty good idea until you rolled over one with a Mojave green rattlesnake under it, and then it bites you and you die. So that's kind of, so it seems like it's a good idea every day until you get renal failure or you get a terrible infection or you get, osteoporosis and break your hip or these things. So it's hard to assess that long-term risk in that case, whereas surgery is an easier thing for people to understand that kind of risk.
Yeah, that's a good point. Okay, so Coffee asks, what is the most effective between EV, LINX, and TIF?
EV, what's he talking about EV? So LINX and TIF. LINX is a bracelet that goes around the esophagus. It's becoming less popular. It is associated with sometimes significant dysphagia, and there is a not an insignificant rate of taking those things off, at which point you're back to where you were. You don't have a reflux operation. And so there are guys doing them. I took the course. I never really felt that was a great idea, putting a foreign body around the esophagus. So that is one of the problems. It is a foreign body on the esophagus. The risk of erosion, the risk of scarring, risk of trouble swallowing afterwards. There are some people that have great results with it, though, so I'm not going to say it's not the way to go. The TIF uses your own tissue to create the wrap, so there's no foreign body. You put these little fasteners in that are like Prolene sutures. We've used Prolene forever. And it's minimally invasive. The serious adverse event ratio is less than 0.5%. It's really a safe procedure. So I prefer that. I prefer using native tissue as opposed to implants or metal implants in that region particularly.
Yeah, So he said EV is the esophageal, I think you brought it up earlier, the esophageal vulvoplasty.
So that's, so there's that's kind of a thing where they're kind of getting stitches in there and doing things, but it's not as, so a TIF procedure is a very regimented procedure that, when I teach the TIF course, we teach it and how to do it. It's very safe and it's very regimented in how you do it. So everyone's kind of doing it the same. A valvuloplasty with stitches and things going to be kind of an artistic approach by the surgeon doing it. So it's just not that much out there on these valvuloplasties if you're using an endo stitch to create it or these other things. TIF, again, has been out for a much longer time. It is fairly standard approach of how we do it. The learning curve on it is fairly low, particularly compared to a Nitin. So we have some data that about 23 of these operations, you do 23 TIFs, and you're pretty good. Your wraps are good, and your times to doing them are good. So, yes, a valvuloplasty is just a little bit, like I said, it's kind of an artistic thing based on what the surgeon's doing and what you're accomplishing. It's hard for me to comment on.
Yeah. Well, I appreciate that. Okay, so the last thing I wanted to talk about is next month, April, is Esophageal Cancer Awareness Month. And I thought maybe that you could maybe give a little insight to those that potentially have a loved one or someone, or they themselves might be at risk. What are the things that they can do to help in that situation or for awareness?
Is a really tough disease. It's a really bad cancer. And it doesn't give you too many signs or symptoms. It's happening. By the time it presents, it's usually with dysphagia or trouble swallowing. You'll see someone tapping their chest at the dinner table. We know that the demographic on that are white males, obese, and they have hiatal hernias, right? So those patients tend to be the ones that get this disease, a precursor disease to it is called Barrett's esophagus.
Right.
So that's what we want to do. We want to find the people with Barrett's and put them in a screening program so we can pick it up earlier. And so we know that just like colon cancer, we're seeing Barrett's at an earlier age, right? So just this year, American Cancer Society recommend getting your colonoscopy at age 45 to 50 because a younger population is getting their cancers earlier. And we're seeing that with Barrett's esophagus too. Barrett's at an index endoscopy is becoming much more frequent. So if you're a white male generally and you're getting a colonoscopy and you've had reflux for over 5 years, recommendation that you get an upper endoscopy at the same time. So you can be evaluated to see if you have Barrett's and you can be put into a screening program to be followed. Again, it's just one of those things where they have techniques where you can burn off this Barrett's. You can do endoscopic mucosal resections, endoscopic submucosal dissections. There's all kinds of newer technology to treat Barrett's and Barrett's dysplasia, and it never gets to cancer. And that's got to be our goal. It's got to be our goal to not let it get to cancer, because once it gets to cancer, it's really hard to cure, has a very high mortality rate, and it's just a brutal cancer. So I would say, get screened is the most important thing. If you've been on these pills for a long time, you've had reflux for a long time, even if it's under control, you have good symptom control, don't assume something's not happening at a cellular level. And the only way you can assess that is with endoscopy.
Perfect. Thank you so much, Dr. Murray. I appreciate that. We're getting a lot more questions, so I'm not going to keep you much longer, but what I will do is we will try and answer the questions that are coming up online for them. Right. But I do want to thank everybody for joining us today, and we plan on doing more TIF Talks, maybe at least once a month, and answer your questions. So please follow our GERDhelp.com page. So you can learn more about the TIF procedure and your GERD symptoms and how to treat those and how to keep yourself aware. And then also you can visit our GERDhelp.com website, where you can find physicians. I see a lot of questions coming up asking where can I find a physician near me. So our GERDhelp.com website has a physician finder where you can find a physician that's located near you. And you can potentially reach out to them and get screened, as Dr. Murray would say. So, Dr. Murray, I can't thank you enough again for joining us today. We appreciate it. And stay safe, everybody out there. And stay safe and healthy. And thank you again for joining us today.
All right.